This is Mon Health Talk, a weekly program focusing on the dedicated physicians, nurses, and staff at Mon Health, the region's premier community hospital system. People with skillful hands and bright minds using state-of-the-art technology. We don't just practice medicine, we care for people like family. That's why at Mon Health you can feel the difference. Once again, welcome to this edition of Mon Health Talk.
Good morning. Welcome into the program. I'm Dave Wilson. Our guest this morning is Dr. Matt Cindric, vascular surgeon with Mon Health Heart and Vascular Center. Of course, February is Heart Month. Dr. Cindric, good morning.
Good morning, sir.
Well,
I appreciate the opportunity to get online and talk today.
Well, we'll dive into it. We're going to be talking, obviously, about vascular surgery, which makes an awful lot of sense on the program today. But before we jump into the topic, talk about yourself for just a minute. Tell folks a little bit about your background, where you're from, your education, training, and how you ended up with Mon Health.
All right. Well, I'm actually a local. I was born in Uniontown, Pennsylvania, and I completed undergraduate studies as well as medical school here at West Virginia University in Morgantown. I subsequently relocated to central Pennsylvania. There I went through general surgery residency at Geisinger Medical Center in Danville from 2004 to 2009. I stayed on there to complete vascular surgery fellowship training in 2011, and then stayed approximately 9 years on staff there as a clinician before I ended up relocating out of that area.
So you're relatively new to Mon Health.
I was onboarded here approximately 3 months ago.
So
that's correct.
Really new. I said relatively new. That's really new to Mon Health. How you liking it so far?
It's been very uplifting so far. I think there's a lot of good people around that are working very hard and are very centered around patient care. It makes it's a very easy system to work within.
All right, we're going to be talking about vascular surgery today. When we talk about the vascular system, what are we talking about, doctor?
Well, as a vascular surgeon, I basically manage diseases and disorders of the blood vessels throughout the body, with notable exceptions to the heart and any vessels inside the head. They're pretty much outside of the heart or the head, then anything related to circulation falls generally under my purview. Most of the problems that we fix are related to the arteries, only occasionally getting involved with problems with the veins. Common problems for which a patient may see a vascular surgeon include aortic aneurysms, carotid disease, blockages in the blood vessels to the extremities that impair walking, or potentially give a person wounds on their feet that they can't heal. Also, we occasionally get involved with access for hemodialysis for patients on dialysis.
What drew you to this specialty?
If we had a couple of hours, it was the play-by-play is very difficult, but I always knew that I wanted to be a surgeon. I always liked working with my hands, but unlike my prior endeavors at, waxing cars and building houses, I liked working with my hands, but I wanted something intimate that I can help people out with. And so surgery became sort of the natural outlet for what I wanted and what I thought I could do. It wasn't until about halfway through general surgical residency that I had a eureka moment when I was introduced to vascular surgery, and it's been a pleasant addiction ever since.
Talking to Dr. Matt Cindric. He's our guest this morning, vascular surgeon, Mon Health Heart and Vascular Center. So what is your role kind of in the heart team, if you will? You've got cardiologists, you've got different physicians who, will factor in. So what is the vascular surgeon, what is your role in that team?
Well, as it relates to the heart, not so much directly with heart conditions. I mean, the cardiologist, as are the appropriate medical doctors for most, cardiac conditions. The cardiothoracic surgeon, of course, is the surgical support for heart-related conditions. I don't have much direct influence with the heart itself, but most of the patients that we treat have a lot of parallels, where if they need to see one provider, they also need to see another provider. I mean, hardening of the arteries is usually a body-wide process. So if someone is seeing my associate, Dr. Nagy, for coronary artery disease, then likely the person is also going to see me for carotid disease or peripheral arterial disease. So a lot of times we collaborate very intimately on the same patient to try to centralize their care, and there's a lot of direct connections between me and the cardiologist and also the cardiothoracic surgeons, just given the common conditions in these patients.
Yeah, you mentioned some of the conditions that you treat, but just give folks a general idea. When would they come see you?
Well, I would say the bulk of the modern practice for vascular surgeons in America is for the management of lower extremity blockages. Honestly, it falls under the radar for the most part. It's often not thought about, but it's a pandemic in its own right. It increases age by decade. A lot of the common symptoms are pain with walking, where the muscles get crampy and sore and tight and tired. The medical word for that is claudication. We get referred a lot of people who have problems with walking based on that. Now, of course, it's not the only thing that can cause problems with walking, but it's one of those things, and it should be thought of. If a patient has that symptom or a primary care doctor kind of gets the tip off that, hey, this might be the symptom, they could send the patient to me for evaluation. If the disease is far more advanced, a person may have chronic intractable pain in the feet, numbness in the toes, cold feet, or get wounds that they unfortunately cannot heal as a precursor to gangrene and amputation. And hopefully the problem could get identified and the patient could get sent to me more expeditiously so we can intercept it and fix the problem and avoid that complication.
Our guest this morning is Dr. Matt Cindric, vascular surgeon, Mon Health Heart and Vascular Center. And we'll continue the conversation in just a moment. Got to squeeze in a break. You're listening to Mon Health Talk on the voice of Morgantown, WAJR.
This is Mon Health Talk, providing a window into the Mon Health system and the dedicated healthcare providers who work there. If you'd like to comment or ask a question, please call 304-296-0041.
Our guest this morning is Dr. Matt Cindric, vascular surgeon, Mon Health Heart and Vascular Center. I want to ask you about some of the procedures you perform. What is, I think I'm saying this acronym right, what is a TCAR procedure?
Sure. A TCAR is an acronym that stands for Transcervical Carotid Artery Revascularization. And basically, a TCAR is the newest treatment modality that we have for management of carotid disease. And it involves placing a stent from an incision just above the collarbone. Traditionally, the stenting has been utilized from the femoral arteries in the groins. And of course, there's the surgical alternative that it's been around since 1957, where you make an incision in the neck to clean out the artery called an endarterectomy. A TCAR, like the other procedures, has basically only one purpose. It's to reduce the risk of a future disabling stroke. It's commanded a lot of attention just because it's newer and it's more fashionable, and it definitely has a role in the management of carotid disease.
So for this procedure, you go in at the collarbone instead of, usually I think of those stents going in through the groin like you mentioned, but this is up around the collarbone?
Yeah, there's two reasons for this in the philosophy of the trouble, or for the reasons of the limitations of a stent from the groin. There's two specific things that can be avoided with this approach. So by making the incision above the collarbone in a non-diseased part of the carotid artery just above the collarbone, it's working through a very short distance to deploy the stent in the diseased portion of the artery. There's two big differences. By a lot of people that have blockages in the carotid arteries also have blockages in the arteries in the aorta and the chest. And one of the hazards of approaching it from the groin is that as you're delivering your devices, wires, and sheaths up through and going through this very serpentine vessel that has plaque on the edges or outsides of it, the plaque could shear off and go to either side of the brain and cause a stroke. So one of the reasons for a TCAR is that you don't have to negotiate a diseased aorta. You can directly get into the artery without that hazard. The other reason is there's a method of filtering the blood flow from the groins that we do differently for a TCAR. There's actually a flow reversal system that in the critical move of passing the stent and then blowing it up and inflating it to trap the plaque against the wall, we're actually reversing the blood flow from the brain momentarily, and plaque cannot go to the brain if the blood flow is going in the opposite direction. So that's the safety net with the TCAR, and one of the reasons it's gained popularity.
And the goal of this procedure with the stent, I would imagine, is to make sure that the blood keeps flowing and you don't get that blockage that could lead to, obviously, a serious stroke and serious ramifications down the road.
Right. The TCAR, like every other carotid stent or the operation, is to clean out the plaque to prevent a stroke. That's the primary goal for all of these procedures. Most strokes are not related to a critical drop in blood supply. Sometimes they are, but most strokes are related to debris from the plaque flecking off and traveling, I say downstream, but it's upward to the brain where it lodges into small vessels and then causes a stroke. So the stenting doesn't necessarily clean out the artery. It tries to open it up wider and then trap all the stuff against the wall so it can't move and go to the brain.
What are we talking about when you say carotid artery? What do you mean? Can you describe that?
The carotid artery is just a vessel that goes up there on either side of the neck. We have a left one and a right one that travels on the front side of the neck to travel and give blood to the bulk of the portions of the brain in the front and the middle section of the brain. There are two arteries that go to the back of the brain that are often not discussed. They're called the vertebral arteries that come off of the arm arteries. They also supply blood flow to the back of the brain and the deep portions of the brain.
So how? Go ahead. Sorry, finish your thought.
No. I was just waiting for you to follow up.
You're waiting for me to jump back in. Sure. So can we take steps to reduce carotid artery disease?
Well, absolutely. So carotid artery disease is just one territory of the underlying problem of atherosclerosis or hardening of the arteries. There's 5 major risk factors for hardening of the arteries. Now, this is true whether we're talking about carotid artery disease or coronary artery disease or disease in the blockages in the vessels of the legs. They're all related to plaque. So those 5 major risk factors are, number 1, genetics. That's the one that we can't modify. Of the other 4, there's something we can do something about. And one is smoking. That's the second one. That's a big one. That's by far and away, that's probably the chief risk factor. And then 3 things I tell patients are related to blood: high blood pressure, high blood cholesterol, and high blood sugar or diabetes. To the extent that any one of those 5 are present, trying to find some resolution and mitigate those things and bring the values back into normal is imperative to prevent further disease progression and plaque buildup.
As we get ready to go into the break, I've done this show enough times to know at some point, I'll let you go ahead and mention it here, you're going to bring up diet, exercise, and quit smoking or don't start at all at some point, and those seem to be very applicable when we're talking about the subject here we're talking about today.
Oh, clearly they are. I mean, it's diet and exercise is sort of standard basic maneuvers. And as it relates to control of those risk factors, and then also for just generalized fitness. I mean, exercise in particular can help, mitigate blood pressure problems as well as getting diabetes into check for people who are unregulated, in addition to other medicines that should be applied for people that have hardening of the arteries.
Yeah, I think actually that applies each and every week. It doesn't matter what we're talking about on the show. I think those are just 3 good rules to live by. We're talking to Dr. Matt Cindric, Vascular Surgeon, Mon Health Heart and Vascular Center. Got to get another break. We'll continue our conversation right after this. You're listening to Mon Health Talk on the voice of Morgantown, WAJR.
This is Mon Health Talk, providing a window into the Mon Health system and the dedicated healthcare providers who work there. If you'd like to comment or ask a question, please call 304-296-0041. Our
guest this morning is Dr. Matt Cindric, Vascular Surgeon, Mon Health Heart and Vascular Center. Of course, February is Heart Health Month. And Dr. Cindric, what is abdominal? I knew I couldn't get through that. Abdominal aortic aneurysm. What is that?
Well, the abdominal aorta, or the aorta in general, is the biggest blood vessel in your body that exits the heart and then gives various branches to everything else in the body. So it's the main pipeline. With respect to abdominal aortic aneurysm, an aneurysm is basically a swelling of the blood vessel. If you want to think of a layman's analogy, think of a water balloon that gets overinflated. The wall of the aorta expands and degenerates to make the blood vessel bigger until it pops and you die from internal bleeding. So it's more common to have an aneurysm in the belly than it is in the chest for a lot of reasons that are a little obscure. It's much more common in men than in women. It's way more common in smokers than in non-smokers as a population. And it definitely occurs more prevalent with the aging process. It's something you're not going to find in 30-year-olds, but it becomes much more relevant in the later decades of life.
Is this something that would be part of a normal screening, or is it something that gets added later in life, as you said? What's kind of how do you monitor for this?
Well, I mean, this is a complex subject in its own right, but there's different societies and different guidelines that are recommended for screening purposes. The Medicare has their own guidelines. The Society for Vascular Surgery, the American Heart Association, they all have guidelines that are similar, but they're not sort of completely alike. The general point is that males who are over 65 should get a screening, particularly if they have been a smoker. That's the general point that Medicare guidelines are. The Society for Vascular Surgery recommends that between ages 65 and 75, male or female, that everyone gets screened if they were a smoker. That applies to everyone in general. If there is a family history of aneurysms, because some of these can be genetic, they need not be genetic, they can be genetic. If there is a first-order relative, like a parent or a sibling that has an aneurysm, then first-order relatives should also be getting screened at the appropriate age, regardless of their smoking status.
If you are screened and something is detected there or shows up, what's the next step?
Well, often when they're found, they're still small at the time that a screening is accomplished. Sometimes they're large and of what we call surgical size at the time that they're detected. I mean, if it's an aneurysm that is small and not quite at the size that we would merit repair, then we get the patient in the clinic, counsel them regarding the natural history of the disease process, and make the determination of when to get the next diagnostic study to reevaluate the size of the aneurysm, as well as go through the therapeutic options of how we go about fixing them and what that would entail. That if it's at the size that on a screening that it's already large enough that we have to talk about surgery, then we're not ordering follow-up studies. We're just getting geared up to how to fix it. And there's two basic methods for repair. The old-fashioned way is everyone used to get aortic replacement with a surgical graft by cutting open the abdomen and replacing the ballooned-out blood vessel. The era of the 1990s and into this decade, there's a constant endovascular revolution where more and more of these are getting fixed with fabric-covered stents from the groins without making any cuts in the abdomen at all to replace the blood vessel. The analogy there is rather than cutting out the blood vessel and sewing in a synthetic pipe with a suture that's the same caliber as fishing line, here it's kind of like fixing a tire by putting a new inner tube in a tire by going through the valve stem. We're working from the groins to reline the aorta with a fabric-covered graft. It doesn't get rid of the aneurysm, it just depressurizes it so it's not going to continue to increase in size.
That sounds fascinating, and we're quickly running out of time, but I would imagine that also means quicker recovery time for the patient. It sounds much less invasive.
It is much less invasive. About 75 to 80% of people in the modern era can get an endovascular repair. It used to be under 50%, but as the device technology continues to expand, more and more people have that modality that can be applied. Most people are walking out in the next day out of the hospital, getting discharged, walking to their car. It's a night and day recovery. It's much simpler. It does not mean that it's a less degree of complications. It's still a dangerous surgery, so to speak, and we have to counsel people on all the things that could happen. But when it goes smooth, it's fairly straightforward. People are back to routine activities within several weeks.
Absolutely amazing to me. Dr. Matt Cindric, vascular surgeon, Mon Health Heart and Vascular Center. You can learn more over at the website, monhealth.com/heart. Dr. Cindric, thanks for taking some time with us today. Appreciate it.
Well, thanks for having me on the show.